Administrators have to come up with that on their own. So they come up with that based on their demographic and their ability to disseminate information and control the environment. And that's not so easy. So in the VA, the Pain as a Fifth Vital Sign toolkit was released. And in general, the way this looked was mandated clinician education and mandating that all nurses performing any intake had to ask, what is your pain rating 0 to 10? They had to ask it and document it and ask it in any clinical setting. And if you actually dig down in some of the language here, you can see some interesting things. Ask the patient what pain rating would be acceptable or satisfactory to him or to her. This helps set a realistic initial goal. This sounds so clean and tidy, doesn't it? Zero pain might not always be possible. Clean and tidy. But then if you dig deeper, you actually see that the initiative required not only that nurses ask patients every time, every interaction, and document it, but beyond the documentation of pain intensity, that a pain score of 4 or higher would trigger a comprehensive pain assessment and prompt intervention. 4 or higher. This is what the National VA decided to do in order to operationalize the pain standards. So I ask people who live with pain, people who live well with pain, we have a number of them here in the room. Is 4 a number you would say keeps you from doing these things? Is 5? Is 6? Is 7? I think that's impossible to say. I can't say it because I don't live your pain. But this is pretty conflicting, right? The person's supposed to tell us what's acceptable, but if they say higher than 4, well then we have to act, right? So it creates this element of need for the clinician to do something, this pressure, I have to do something, and limited clinical tools, limited clinical times makes for not such good outcomes. All right, they've gotten a lot of flack for this, okay? So in 2016, the president at the time actually wrote a rebuttal and published it. We never said to, we never told you to, people. But different hospital systems take this action differently and they try to operationalize differently, but that doesn't mean it's not changeable, and that's what I'm on a mission to do where I currently work, and it's not easy, even though I'm fired up about it. I don't quite have the level of excitement that Sharna has today, but you see me at work and that's how people would describe me in my circles. So I relate to that. I appreciate that very much. So jumping over briefly, around the same timeline, 2002, remember 2001 was the Joint Commission Standards on Pain, this thing called HCAPS, Hospital Consumer Assessment of Healthcare Providers and Systems, which is mandated by the Centers for Medicare and Medicaid Services. Now, all that's mandated is that these scores are taken, these surveys are delivered to patients in hospitals and publicly reported. That's all that's mandated. And the survey is nothing more than 27 questions asking the person what they thought about their hospital stay. In a consumer-based society, that sounds great, except that's not so easy to apply to a major hospital system with a lot of moving parts and a lot of risks to manage and a lot of unintended consequences if you just do what a person would think is best, like, I don't know, have soft music and no noises and all that stuff is important. I agree with that. Pain management is among the domains that's asked. But here's the kicker. Hospitals stand to lose money, not only reputation, but profit if pain is poorly managed by report of the person in pain, right? So if we're requiring that we ask them 0 to 10 and they hate being asked that question, that by itself will result in a poor survey score, right? Not understanding the problem. And evidence suggests that higher levels of pain and depression, this is no-brainer, are linked to poor satisfaction in ambulatory care settings. You all know that, you feel that, right? If people don't feel heard and don't feel cared for, their pain will be higher, very likely, because of a number of factors that have been discussed here this weekend. And it's not simple. Now, you might have been in the hospital recently, you might have a loved one in the hospital, and you might have felt that this dummy got better care than your loved one did. But that doesn't necessarily mean when we're looking at metrics for other health outcomes that bad surveys mean bad care. This is the tricky thing about trying to rely on subjective report surveys to run huge organizations. I am not a huge advocate of just pushing policy. I just want to reflect on the complexity of this problem.